Alright guys, this is Dr. Manish Chhabra, your ophthalmology educator. Now in this short video, I am quickly going to discuss Rajasthan medical officer exam questions, and with a special thanks to Dr. Sadiq for sharing the questions with me. And my idea will be not only to tell you the right answer, but also to discuss the near about points so that when this topic gets repeated, you are able to crack the code. Okay, so let's start with the very first question. Prominent corneal nerves may be seen in all of the following except. If you have ever attended my class, I always stress upon learning the causes of prominent corneal nerves. So it was not an image based question, but I have put in the image for better understanding. So here you can see that there are prominent corneal nerves. In which cases it may be seen? It is seen in leprosy, neurofibromatosis, keratoconus, and acanthamoeba. So this was a pretty straightforward question. So which is odd one out? It is herpes simplex keratitis. Okay, so this is odd one out. So you are going to mark herpes simplex. So there are many reasons, but these four reasons you should know. Prominent corneal nerves, and if I take it a step higher, you know that there is a trigeminal nerve. The ophthalmic division of trigeminal nerve is there, which gives a branch to nasociliary nerve. The nasociliary nerve give a branch to long posterior ciliary nerve. Long posterior ciliary nerve forms the subepithelial plexus of nerves. Subepithelial plexus of nerves. It is these nerves we are talking of. It is corneal nerves. Okay. All right. Now coming on to secondary glaucoma following corneal perforation is due to. Now boys and girls, this is a slightly controversial question. Now the trauma can be of two types. One is your blunt trauma, another is your penetrating trauma. So we mostly read about blunt trauma, but they have specifically given penetrating trauma. We'll try to connect the dots. Blunt trauma, there can be hyphema. Why there is hyphema in blunt trauma? Due to rupture of major sulcus arteriosus, which is present at the root of the iris. Remember, major sulcus arteriosus, it is the anastomosis between the long posterior ciliary artery and the anterior ciliary artery. So when there is trauma, it gets ruptured, leading to extravasation of blood in the anterior chamber, leading to hyphema, which clogs the trabecular meshwork. Yes, there can be another cause of glaucoma, which is ghost cell glaucoma. Ghost cell can also be seen in blunt trauma. It is actually the RBC which gets stuck in the trabecular meshwork. Third is angle recession. Angle recession is tear between circular and longitudinal muscles of the ciliary body. That can also lead to glaucoma later. Now coming over to penetrating. So they have specifically asked for perforation. So penetrating means some foreign body has entered into the eye. Now when the foreign body enters into the eye, number one, it can lead to hyphema. The same way it will lead to raised intraocular pressure, but mind you, this hyphema can only happen if this small penetrating body hits the point where there is blood vessel, like at the root of the iris, on the iris. Yes. Second, if there is damage to the lens, which will lead to lens swelling. So when it will get swollen up, it will shallow down the anterior chamber. Third, when there is trauma penetrating, there is perforation, which will lead to coming out of aqueous humor. Aqueous humor will come out and the eyeball will get deflated and the iris will move back and will try to close the perforation due to deflation. And it will induce inflammation. It will cause inflammation of the iris, which is a part of uvea, which will cause uveitis. Now this uveitis will lead to cells in the anterior chamber, proteins in the anterior chamber, which will make the aqueous humor very thick, very turbid, which will slow down the passage of aqueous humor from the anterior chamber into canal of Schlemm via trabecular meshwork. And post uveitis, it can lead to synecdoche formation. Now these synecdoche will be your peripheral anterior synecdoche. You remember which is the most common complication of uveitis. It is secondary glaucoma due to, of course, peripheral anterior synecdoche formation. Number one. Second, the aqueous humor will become very thick, very turbid. Okay, now after this, getting back to the options that we have. So hyphema, so I told you hyphema will only happen when this foreign body will particularly hit at a point where there is blood vessel. There are less chances. Yes, so hyphema is eliminated. Angle disruption, angle recession, no, it is seen in blunt trauma. Peripheral synecdoche or anterior synecdoche formation, what is difference? So peripheral synecdoche is very vague option, peripheral synecdoche, but anterior synecdoche, you know, peripheral anterior synecdoche, so I am going to pick out anterior synecdoche. So peripheral synecdoche, it can be anterior synecdoche, it can be posterior synecdoche, and you know, if it is posterior synecdoche, it will lead to cataract formation, not glaucoma. But anterior synecdoche, of course, is going to lead to glaucoma. So this is the answer to be picked. Okay. Okay. Now let's move over to the next question. So it is the grading of trachoma. So trachomatous inflammation, follicle is defined as the presence of. So we are talking of the classification of trachoma, which is Fisto classification. This is your WHO classification. Now I want to show you this Fisto classification. So F for follicles, and the minimum follicles which should be present should be 5. Now I for inflammation. So inflammation is such that it obscures more than half of normal deep tarsal vessels. Then S for your scarring. Remember a term which is Art's line. Don't confuse Art's line, which is present on the palpebral conjunctiva, more pronounced on the upper palpebral conjunctiva. It is a scar in trachoma. Don't confuse this with that of Art's triangle. Art's triangle is seen in acute anterior uveitis. It is the arrangement of keratic precipitates at the bottom 1/3 of the cornea. है ना? Okay. Then is trichiasis. Trichiasis is misdirected eyelashes. Minimum one misdirected eyelash will make you think of Fisto ka T. Yes, trichiasis. And O is when there is blinking with the trichiasis, it is constantly going to rub upon the cornea, which will cause epithelial defect, which will induce inflammation, which will cause corneal ulcer, and the sequelae of corneal ulcer will be corneal opacity. So that is your Fisto classification. Now getting back to our question. So how many follicles? We have just done 5 follicles. So that is the answer, my dear friends. Done? Okay. Now moving ahead. A 40-year-old man undergo a routine eye exam with an irregular pupil, and matlab they are talking of one unilateral, है ना, which is non-reactive to light but accommodates well. So light reflex is absent while accommodation reflex is present. Now in which condition this may happen? It may happen in Argyll-Robertson pupil and Eddy's-Tonic pupil. What happens in Horner syndrome? There is damage to Horner's pathway. Horner's pathway is the sympathetic fibers coming from hypothalamus going till C8, T1, T2. Then they will move anteriorly between the clavicle and the tip of the lung. Anteriorly come to lie inferior cervical ganglion. They will go towards superior cervical ganglion, loops around internal carotid artery, enter into middle cranial cavity, then goes ahead in the orbit, supplies the dilator pupillae. 1. So the features of Horner's syndrome are enophthalmos, ptosis, meiosis, and hydrosis. Now you just need to hear what I say. Enophthalmos is sunken eye appearance, but the ptosis is due to damage to Muller's muscle. Muller's muscle, not levator palpebrae superioris. Levator palpebrae superioris is supplied by third cranial nerve, which will cause full ptosis. Muller's muscle is supplied by sympathetic fibers which are damaged, and there is just 2 mm of the ptosis. Due to 2 mm of the ptosis, it appears as if the eyeball has sunk in when actually it hasn't. So enophthalmos is not true, it is pseudo. And meiosis is pupillary constriction. So blanket constriction of the pupil, no effect of accommodation reflex, light reflex, so blanket. So this option is eliminated. Third nerve palsy, you know what will happen. Third nerve causes constriction of the pupil by stimulating sphincter pupillae. Now in third nerve palsy, the pupil will be dilated, not constricted. Oculomotor nerve, because it supplies sphincter pupillae, it will be dilated and fixed. No reaction to whatsoever. Yes. This is also eliminated. Also, there will be full ptosis. There will be extraocular muscle movement restriction. Now coming down to these two. So Argyll-Robertson pupil, the common cause is neurosyphilis. It is neurosyphilis. Addy's tonic pupil, the common cause is ciliary ganglionitis. Now in both the pupil, there is accommodation reflex which is present and light reflex is absent. How will you remember? ARP, accommodation reflex is present. Reverse it. PRA, pupillary light reflex is absent. Done. In Addy's tonic pupil, this also happens. But Argyll-Robertson pupil is a bilateral condition and this is your unilateral condition. Argyll-Robertson pupil, the pupil may also be irregular. Yes, but there is a small, I think there can be a small controversy because they have said irregular and irregular pupil, matlab they are talking of one eye. But unilateral dilated pupil normally is seen in Addy's tonic pupil and bilateral constricted pupil is seen in your Argyll-Robertson pupil. But based on the history, if you connect the dots, the answer goes more in favor of your Argyll-Robertson pupil. Yes. Okay, but let me just show you a case of Addy's pupil. Very beautiful case. So you can appreciate left eye unilateral dilated pupil not reacting to light. Yes, but when I'll ask the patient to focus on the camera, you will see that the pupil will constrict. Now check this out. Can you see the pupil has constricted? Okay. Now I am asking the patient to look at a wall behind me. Now suddenly I am going to ask the patient to look towards the camera. You will see the pupil getting constricted. So light reflex absent, pupillary accommodation reflex present. Is it understandable, boys and girls? Wonderful. Okay. So this is your Addy's pupil. So the best option to pick is Argyll-Robertson pupil. Now next is, and you also saw Addy's pupil. The pupil was round. It was not irregular. A 65-year-old male presents with sudden loss of vision in his right eye. Dilated fundus examination reveals a pale retina and a cherry red spot. Okay. So sudden loss of vision is seen in which conditions? All four conditions can present with sudden loss of vision. RD, retinal detachment, sudden loss of diabetic retinopathy. There can be retinal detachment, there can be cystoid macular edema, sudden loss of vision, central retinal arterial occlusion. Now let's eliminate the option one by one. They are specifically told that the retina is pale or milky white. What about central retinal vein occlusion? There will be multiple hemorrhages. The appearance of the retina will be splash tomato appearance. There can be disc edema which can be associated. There can be macular edema which can be associated. There will be 100-day glaucoma. There will be dilated and tortuous vessels. Yes, that is what you see in central retinal vein occlusion. So they have just mentioned loss of vision and the fundus examination does not go well with what they have suggested. So it is easily ruled out. Now, diabetic retinopathy, there will be typical dot blot hemorrhages. There will be exudates. Exudates can be soft exudates. It can be hard exudates, soft and hard. There can be neovascularization because they have just mentioned diabetic retinopathy, not non-proliferative or proliferative. Neovascularization can happen in proliferative diabetic retinopathy, right? There can even be macular edema in both NPDR or PDR. Yes, but again, it is not going well with the history which is provided. Yes, this is also ruled out. Now, retinal detachment. What happens in retinal detachment? So, there will be leukocoria. Leukocoria is white pupillary reflex due to detachment of the retina. Okay. There can be presence of pigment in the vitreous cavity. You call it as Schaffer sign. Pigment in vitreous cavity, which is Schaffer sign. Of course, the loss of vision will be sudden, painless, but the retina will not be pale. When you will do fundus examination, you will see that the retina has got a blood supply, but there will be no cherry red spot. No cherry red spot. Okay. But what, so this is also ruled out. So we are talking of central retinal arterial occlusion. So what will be the features of CRAO? So there is sudden cessation of the blood supply in the central retinal artery leading to pale or milky white retina. Now what happens is, in the center of the macula there is fovea, through which you can appreciate the choriocapillaries wala red dot, the blood supply in the choriocapillaries region. You can appreciate that, but you can only appreciate if the surrounding retina has gone pale or milky white. That is why there will be a contrast difference which will be established. But normally when the retina is fine, there is blood supply, retina appears red, and if you will try to appreciate cherry red spots, you will not be able to appreciate because of the surrounding red retina. Okay, but when there is pale or milky white retina, this cherry red spot which is present at the macula, it stands out. So you are able to see the cherry red spot only in CRAO. Of course, there are some differential diagnosis. There are some storage diseases, biochemical storage diseases, in which you have cherry red spot like Gaucher's disease, GM1 gangliosidosis, Sandoff disease, Tay-Sachs disease, also in Berlin's edema, which is blunt trauma to the eye. Yes. And in this situation, you will have this as the answer. But I'm not stopping here for now. I am also going to tell you the other features. So there is typical cattle tracking. Cattle tracking is seen. That is due to the formation of column of blood in the vessels in the retina. Cattle tracking. And how are you going to treat it? So there is a sequence of therapy. First and foremost is you go for massage, ocular massage. So if the patient has come, you just do ocular massage. This may sometimes dislodge the obstruction. What is the obstruction? Obstruction is typically Holland-Horst plague. Holland-Horst plague is a cholesterol plague, your previous year question. So by just massage, you can dislodge the obstruction first. Second, you give intravenous mannitol. So this decreases the intraocular pressure. It starts its action in 20 minutes. It decreases intraocular pressure so that there is sudden gush of blood. The counter pressure is decreased, which is inside the eye. So there is sudden gush of blood that may dislodge the obstruction. Third is paracentesis. So mannitol will start its action in 20 minutes while you put a needle in the aqueous humor, means anterior chamber, pull out some aqueous humor. It is suddenly going to decrease the intraocular pressure. That may even lead to the flow of blood in the central retinal artery with more force, which may dislodge the obstruction. So this is the best technique. The other are, you can go for carbogen inhalation. Carbogen is 95% oxygen, 5% carbon dioxide. Fifth is intravenous tissue plasminogen activator, which is thrombolytic. But the best is paracentesis. Mind you, retinal ischemic time is the time in which, if the blood circulation is restored, not even a single cell of retina die. It is 90 minutes. While the critical period is the period after which you will treat this obstruction, not even a single cell will left. It is 12 hours. So anyway, you have to first resolve the condition in 90 minutes. Not even a single cell will die. But if you are resolving after 90 minutes, if you go beyond 12 hours, not even a single cell will be left. So that is about your central retinal arterial occlusion. All right. So boys and girls, thank you very much for spending 25-30 minutes with me. So yes, I have purposefully included the nearby topics so that when you revise it, we are not only discussing these questions, we are also discussing the important PYQs in the PYT. This is your PYT. Yes. Okay. So do give me your feedback. You can follow me on Instagram and my ID is I_Manish. You can also follow me on Telegram. On Telegram, I have started my OMR series, which is 1 minute revision, in which under 1 minute in a rapid fire fashion, I take a topic and tell you all the important PYQs which have been asked before in 1 minute. So you can follow me on Telegram, and the name of my Telegram group is Ophthalmology by Dr. Manish Chhabra. Ophthalmology by Dr. Manish Chhabra. And you can also follow me on YouTube. On YouTube, I have recently started with OTC series. OTC is ophthalmology tuition classes, which is first of its kind in the country, in which I am teaching ophthalmology in the form of episodes in detail, ophthalmology in very detail, specially meant for pro students or the students who did not read ophthalmology well and now they want to understand the complete concept. Even if you are an ophthalmologist who is practicing and want to know deep details, so you can always follow me on YouTube, and trust me, you are going to have a wonderful time. Okay, and the lectures are very small, nearly 40-45 minutes, like you have the lectures in lecture theater. So that is the concept behind OTC, ophthalmology tuition classes. So you can follow me on YouTube, Ophthalmology by Dr. Manish Chhabra. And if you further have any doubts, you can always and always send me a WhatsApp on 9814111330. I'll try to respond to you as soon as possible. All right, best wishes.